A very good afternoon and a very warm welcome to Docplexus. Welcome to this brand new episode of MasterSeries session. So, according to WHO, continuous misuse or overuse of antibiotics worldwide has led to a sharp rise in the antibiotic resistance, resulting from the evolution of microorganisms with new resistant mechanisms. So, managing such antimicrobial resistant infections is a daunting and leads to more prolonged illness and affects treatment duration, hospitalization, healthcare costs, and even the economic burden. So, talking about antimicrobial stewardship, which can be the best solution to overcome this issue. It is a coordinated program promoting the appropriate use of antimicrobials, encouraging better patient outcomes, minimizing microbial resistance, and even decreasing the spread of infections. So, to help us gain more insights on this topic, we have with us Dr. Anil Kumar, Senior Consultant, Head Critical Care Medicine, and Senior Consultant and Head of Department of Critical Care Medicine at Santosh Medical College and Hospital in Ghaziabad. He has an experience of 18 plus years in clinical medicine and is a faculty and course director for various academic courses in critical care medicine and emergency medicine as well. In addition to that, he has more than 30 publications in national and international journals and is also the author of books and short textbooks. Dr. Kumar is a course director for fellowship in critical care medicine and a founder, treasurer, and academic coordinator for the Society of Critical Care and Emergency Medicine. So a very warm welcome to you, sir. Now, please go ahead and start your presentation.
Yes. So good afternoon, all of you. Myself, Dr. Anil Kumar, working as Senior Consultant and Head Critical Care at Santosh Medical College Hospital in Ghaziabad. And today we'll be discussing antimicrobial stewardship and its practical implication in the current scenario. So before going to the antimicrobial stewardship, we must consider what is antimicrobial resistance. According to the WHO, the antibiotic resistance is rising to a dangerously high levels in all parts of the world. It is like a global issue which is emerging and spreading very fast. No hospital is able to afford and actually go through the crisis of antimicrobial resistance. If you see the antimicrobials which has developed over a period of time, if you start from year 1930, a lot of antibiotics have been developed. But at the same time, if you look at the lower end, there is a lot of antibiotic resistance which has been observed, like the antibiotics like sulfonamide initiated in 1930, and we were able to see resistance in year 1940. Similarly, a lot of antibiotics, but if you go on the other half of the slide, no newer antibiotics have been developed. There is a long gap in which new antibiotics were developed. And moreover, the antibiotics which were developed, they are also found to have resistance in the present scenario, which is a major global threat across the globe. Even if you go through the developments to tackle the antimicrobial resistance, there is a lot of developments over the antibiotics, but in terms of how to tackle those, now people have come up with lot many antimicrobial stewardship programs, especially the IDSA Society, CDC, Joint Commission Stewardship, and lot more organizations are working to tackle the antimicrobial resistance, which is the present issue. If you look at the burden of antimicrobial resistance across the world, as per the WHO scenario, they have projected in 2050, we will be having around 10 million people worldwide deaths would result mainly due to antibiotic resistance, which make it even deadlier than cancer. So it is really an alarming situation, the antimicrobial resistance at the present situation. Even there is a global threat of antimicrobial resistance. As per WHO, they have characterized as per the present, considering the present situation, even WHO is considering AMR to be a global threat, and it has classically divided the antibiotics as priority 1, considering as critical, priority 2, considering them as high, and priority 3, which is considering them as medium. It is based on the presence and the severity of infection. Like in priority 1, you have critical microorganisms like Acinetobacter, Pseudomonas, and Enterobacteriaceae. And in like priority 2, it is considered as high. There is Enterococcus faeciens, Staphylococcus aureus, H. pylori, Campylobacter, Salmonella, and Neisseria. So this is also an important global threat considering the AMR in the present situation. If you consider antimicrobial resistance in India, there are a lot of superbugs which are even increasing day by day with the present situation, and most of us are losing battle against the common bugs as they are getting more and more resistance in the present scenario. People are resistant to most of the common antibiotics, what we are observing in Indian population as well, and it is also seen worldwide. There is a lot of emphasis towards the evaluation of antimicrobial resistance in India as well. The latest ICMR national survey was conducted in year 2020, and they have also found to see drastically a very high proportion of antimicrobial resistance which is prevalent in India. They have also classified the antibiotics as group 1, group 2, group 3 as per the WHO. Maybe the organisms could little bit vary, but it is more or less similar kind of gram-negative infections which are more prevalent in our country as well. And considering the antimicrobial resistance, the availability of antibiotics is also limited in the present scenario, which is in India as well as worldwide. This is the WHO same, just I shared the critical, the high, and the medium definition of resistance. This is just a slide to emphasize on multi-drug resistant Acinetobacter across the world. Similarly, we have a lot of ESBL, which is extended spectrum beta-lactamase and Enterobacteriaceae. There is a continuous threat. The entire world is struggling to treat Acinetobacter or the Enterobacteriaceae, and even now people are coming with more gram-positive infection or the gram-positive resistance, which we commonly called in medical as MRSA and as well as VRSA, that is vancomycin-resistant Staph aureus or methicillin-resistant Staph aureus. These are also new, or not new we can say, but we are getting much of resistance in the present situation. This is a data which shows the presence of Klebsiella across the selected countries. And if you see, the Asian countries are also having a high number of Klebsiella resistance as compared to the United Kingdom or United States. But there is significant resistance which is observed across the globe. So if you consider why this antibiotic resistance is developing and why this is a serious concern, it is what I can see, antibiotic resistance is a complex process that occurs because the bacteria adapts to the continuous presence of the antibiotics. And there is modification on the drug part, there is modification on the patient part, and there is a lot of concerns or the modifications which does happen. And if you go back, there are a lot of factors which leads to antibiotic resistance in the present situation. This is a slide which emphasizes or briefly looks at what is the most likely probable cause for antibiotic resistance in the present scenario. It could be overprescription of the antibiotics. Patients are not finishing their treatment on time, or they are continuously taking the treatment or stopping on their own. There is overuse of antibiotics in the livestock or fish farming. Poor infection control practices in the hospital and clinic, lack of hygiene and poor sanitation, and lack of new antibiotics being developed. These are the most probable causes as per the WHO, and which is an immediate concern, which are the most possible causes for antibiotic resistance. If you look at the mechanism why this antimicrobial resistance is being developed, there is a lot of modification. Either we call it as an antibiotic inactivation, the antibiotic which is being prescribed, it is not working. It could be the target modification, antibiotic where it was supposed to work, the target itself has modified the situation to does not act. Similarly, there are pump mechanism called active efflux pump mechanism, which inhibits the protein that removes antibiotics from the cell. And there is some mechanism in which the drug entry of antibiotic is being prevented. So in nutshell, there are 3-4 mechanisms which leads to antimicrobial resistance, which I can again share. It could be either an antibiotic inactivation, either it could be target modification, or it could be an active efflux, or the drug is being prevented to enter. This is also a slide which all just emphasize the where are the antibiotic targets, like beta-lactams, vancomycin works on the cell wall, fluoroquinolones and rifamycin works, rifampicin works on the DNA or the RNA synthesis, trimethoprim sulfonamides based on the folate synthesis. Daptomycin works on the cell membrane, and a lot of antibiotics works with the mechanism on protein synthesis like linazoles, tetracyclines, macrolides. Similarly, if you go back to the other side of the slide, the mechanisms could be that we just discussed: efflux mechanism, fluoroquinolone, aminoglycosides, tetracycline. There is bypass of the immunity or the modification of targets in case of fluoroquinolones, rifampicin, and inactivating enzymes. This is also a serious concern, especially the beta-lactams, aminoglycosides, macrolides. This is a slide which I got to the web, which is the present scenario, what we have been going through this COVID issue for past 2 years. And more or less, there is a lot of, I can say, misuse of antibiotics in the present situation, which is also a major cause which we are seeing a lot of antimicrobial resistance, because most of our patients during the COVID-19 treatment have received a high amount of antibiotics as well as antivirals and a good high doses of steroids to counteract the COVID-19 treatment. So this is also a major future recommendation which people are anticipating. We are seeing more and more resistance in this post-COVID era, post 1 or 2 years of COVID treatments, because most of the population has got COVID treatment or suffered COVID illness or disease during the COVID illness. So there is a lot of concerns related to the overuse of antibiotics, especially in the COVID scenario, and steroids. This is a slide which clearly demonstrates the resistance pattern which is being observed across the globe. Especially, we see a lot of carbapenem resistance in Antibacteriaceae. There are a lot of enzymes which keeps disturbing the overall resistance mechanisms like KPC, NDM, OXA, VIM, IMP, SMP. These are all resistance mechanisms which leads to resistance of the commonly prescribed antibiotics to treat Enterobacteriaceae infections. So there are a lot of mechanisms by which we can detect, but ultimately if you go through, there is a lot of resistance pattern which we are absorbing across the globe. There is a classification as well which is available, known as Ambler classification on the beta-lactamases. Beta-lactamases are the enzymes which keep destroying the antibiotics. The lactamases, basically all the beta-lactamases, they are being destroyed by the beta-lactamases enzyme. And due to this separate mechanisms of antibiotic resistance that we were seeing in like KPC, NDM, VIM, AMC, TEM, lot of resistance mechanisms or the enzymes. So that makes a lot of resistance, especially to the commonly prescribed antibiotics. There is a lot of modifications in terms of the resistance organisms. Now, earlier we were reading only MDR bugs. Now we are going through MDR, XDR, and PDR. PDR is pan-drug resistance, XDR is extensively drug resistant, and MDR is multi-drug resistant organisms. And these are all classified mainly the resistance pattern to the Enterobacteriaceae as well as to the gram-positive organisms as well. MDR we define as when the isolate is non-susceptible to at least one agent in more than 3 antimicrobial categories. XDR when the isolate is non-susceptible to at least one agent in all but 2 or fewer antimicrobial categories. And pan-drug resistant when you have non-susceptibility to all agents in all antimicrobial categories for each bacterium. So now we are moving more towards XDR or PDR in present ICU scenarios or intensive care areas or critical care or internal medicine or oncology patients or immunocompromised patients. We are seeing more and more prevalence of XDR or PanDR bugs. So if you go, what are ESBL? This is also a type which we define where the ESBL are the bacterial enzymes which are capable of hydrolyzing, thus conferring resistance to all the penicillins, first, second, and third generation cephalosporin as well as aztreonam. These are all inhibited by the beta-lactamase inhibitors such as clavulanic acid, sulbactam, tazobactam. ESBL are plasmid-mediated enzymes that confer multi-drug resistance to gram-negative bacteria. ESBL may be co-expressed as well as co-transmitted with chromosomally encoded AMC beta-lactamases. Thus, presence of ESBL may be masked in AMC modifications. If you go over CRE is carbapenem resistance enterobacteriaceae, and CPCRE is carbaminase producing CRE, which is carbapenem resistance enterobacteriaceae. So this is, we cannot evaluate too much of non-carbonidases because we don't have a lot of tools which we can decide which is non-carbonase or carbonase. So for all practical purposes, we are still focused on diagnosis of CRE, where we see a lot of KPCs, NDM, VIM, IMP, and OXA. So based on the present CRE situation across the globe, there are a lot of resistance mechanisms which have been evaluated in the CRE, and as well as the antibiotics modifications to treat those CRE infections. CPCRE by definition, if somebody wants to label somebody as carbaminase producing CRE, we have to have positive for carbaminase production biophenotypic test like modified Hodge or Carba-NP, or we need to have non-susceptibility to at least 3 carbapenem antibiotics with minimum inhibitory concentration more than 2 microgram per ml, or zone diameter less than 22 millimeters, or a positive carbapenemase gene marker. So it is really difficult to label somebody as CPCRE, but if you involve many tools, definitely we can put somebody as CPCRE infection. If you go by the antibiograms which are available through the Department of Hospital Infection Control or Microbiology, you can practice a lot of stewardship, which I'll be dealing subsequently in the goals and observations of the antimicrobial stewardship program. The antibiogram of various hospitals are the local information which is being collected to the isolates which are being developed or which are being grown on the isolates of the commonly cultured organisms in the hospital. So this is a very classical information which every ICU, every hospital setting looks at and decide about their antibiotic practices. This is a slide which I got from CDC. This is just an emphasis because a lot of viral infections does not require antibiotics. They usually improve over a period of time. Either it takes a week time or 2 weeks time, but most of us do receive some amount of antibiotics, which is a special or a more serious concern. And we do receive some small doses of steroids, some anti-allergic, some antiviral, but most of the viral illness are self-limiting. They usually recover within 7 days with our own fight back immune mechanisms. So after considering all this antimicrobial resistance, the various causes for resistance, the various mechanisms, the various types, the various terminologies like ESBL, CRE, KPC, CPCRE, the causes of antimicrobial resistance. Now, actually, if you consider all those antimicrobial resistance which is prevalent across the globe as well as in our own country, there is a high demand to overact or counteract this antimicrobial resistance. So to counteract that antimicrobial resistance, people are coming more and more and towards the development of antimicrobial stewardship program. If you consider by definition, antimicrobial stewardship is an activity that promotes an appropriate selection of antimicrobials, appropriate dosing of antimicrobials, and appropriate route as well as the duration of antimicrobial therapy. This is a very important component of any hospital about a functional antimicrobial stewardship program to counteract this present global burden of antimicrobial resistance. These stewardship guidelines are mainly being endorsed by American Society of Health System Pharmacists, American Academy of Pediatrics, Infectious Disease Society of Obstetrics and Gynecology, Pediatric Infectious Disease Society, Society for Hospital Medicine, Society for Infectious Disease, and even ICMR in our own country is developing a lot more guidelines on the stewardship practices. Even ISCCM is working hard, and they have already developed guidelines for the present use of antimicrobial stewardship in all the ICUs which are practicing intensive care medicine in India. This a slide which has been shared or taken from CDC. These are the core elements of hospital antibiotic stewardship program, which includes hospital leadership commitment, accountability of the hospital antimicrobial stewardship program. We have a pharmacy expertise, or previously it was known as drug expertise. Action, the implement the intervention, audits, feedback mechanisms, authorization, tracking of the antibiotic practices, reporting of the information where what kind of antibiotics are being routinely prescribed, what kind of resistance, what kind of isolates. So this reporting mechanism, the tracking mechanism, and education becomes far more important to develop an antimicrobial stewardship program and to follow. If we educate more and more prescribers, especially the doctors, the pharmacists, the nurses, there is a lot of emphasis towards the educations in the present scenario to develop an robust antimicrobial stewardship program, because education can bring a lot more changes to the ongoing developments in overall improvisation on the antimicrobial stewardship program. CDC is also working to develop the core elements, which they have also modified these core elements as core elements for hospital antibiotic stewardship program, core elements for antibiotic stewardship for nursing homes, and as well as the core elements of outpatient antibiotic stewardship. If you consider all these things, they are interrelated, but they have little bit of modification and the concerns, especially if you look at the core elements of outpatient antibiotic stewardship. It is more towards the administration in the OPD areas, the oral antibiotics, the modifications in oral antibiotics, the duration of oral antibiotics, when to stop antibiotics, how to follow up. If you consider the antibiotic stewardship during for nursing homes, there are different practices in nursing home as compared to a bigger hospital. So there are elements which are being a little bit overemphasized to consider those particular areas of need. If you look at the overall goals of antibiotic stewardship program, it is to improve patient care and provide optimal therapy. Secondly, the goal could be to reduce the collateral damage. It could be the less toxicity, less C. diff infections, less line infections, and the length of or the duration of stay in the hospital. Reduce the antibiotic use, decrease the antimicrobial resistance, and the impact cost, which is to reduce the cost due to less collateral damage and even the antibiotic saving for our future use and for the future generations. This is also a slide which I found very interesting, especially it's a new CDC data, which they say more than half of the antibiotic prescribing for selected events in hospital was not consistent with recommended practicing practices. What they mean to say, like it is as we go more and more data collection, more and more evaluations of the antimicrobials which are being prescribed in the community, there is huge amount of difference in the antibiotics prescribed and the recommended guidelines. So that is why people are developing more and more guidelines, as well as there is more emphasis towards the antimicrobial stewardship in the areas which can be defined as antimicrobial stewardship for hospital, for clinics or outpatient departments, where we do practice or follow, which is the recommended guidelines, because most of us, even in our own country, are observing there is an over rampant use of antibiotics, especially in rural areas, a lot of urban areas, lot of physicians, different kind of physicians, different backgrounds of physicians are prescribing antibiotics for all kinds of infections, whether it is viral, bacterial. It's really a difficult situation what we are going across. So I think there is a huge amount of need to develop more and more antibiotic stewardship in the medical curriculum, as well as to conduct more and more training programs, especially in the antibiotics prescription and the antibiotic stewardship, so that we develop less antimicrobial resistance and we have a better healthy future generations in our own country as well as across the globe. If you consider what could be the goal of antimicrobial stewardship program, the primary goal of antimicrobial stewardship program is to optimize clinical outcomes while minimizing unintended consequences of antimicrobial use. Secondary goal could be to reduce healthcare costs without adversely impacting the quality of care. The potential proactive core strategies could be a prospective audit with intervention and feedback, formulary restriction, as well as the pre-authorization. Formulary restrictions mean there is a lot of formulary restriction, like in our own hospital, we have a restriction to a restricted antibiotics. So there is a group of antibiotics which we call as restricted antibiotics. So they need authorization from the respective heads or from the Department of Microbiology, and they keep on collecting the data. Even there is a restriction to use those antibiotics unless it is indicated. The additional aspects of antimicrobial stewardship could be an appropriate use of antimicrobial is an essential part for patient safety. Frequency of inappropriate antimicrobial use, combination of antimicrobial stewardship and comprehensive infection control has been shown to limit the emergence as well as the transmission of antimicrobial resistant bacteria. If you consider the core team members of any antimicrobial stewardship program, which is a major development in the present scenario, must have a physician from infectious disease background or a critical care physician. They have a very critical role to play. They have to interact with all the medical staff, mediate disagreements, set goals of the program, have to be diplomatic and collegial, have an interest in antibiotic utilization as well as patient safety. It should have a clinical pharmacist. That person should also be preferably trained in infectious disease to liaison pharmacy and members, intervene, set goals of the antibiotic stewardship program, confidence in advising physician and other providers. So these are also very important component, because if you go, there are a lot of pharmacists being attending the routine rounds in ICU and guiding the or going through the prescriptions what my patient is receiving in ICU, and they do have a better communication. Even at times, microbiologists are sharing the information or they are collecting the data, what kind of antibiotics, what kind of resistance mechanism, what kind of combination will work in this scenario. So I do have a lot of respect for those who are really helping us in deciding an antibiotic plan, especially when we are treating more and more sick patients in intensive care setting. The other core support team could be an infection control team, quality assurance team, the information technology, the hospital epidemiologist, microbiology. The core team, again, I said it could be an infectious disease physician or a critical care physician, clinical pharmacist with infectious disease training. The collaborative team could be medical executive, pharmacy and therapeutic committee, the hospital administrator, as well as the pharmacy director. So if you see this slide, this is, I think, the entire team which works in hand together to develop and to follow the antimicrobial stewardship program for the hospital to have a better outcomes as well as decreasing the incidence of antimicrobial resistance. The other elements for consideration and prioritization could be educational program with active intervention. With active intervention, we means if you educate somebody, we should have that person further educating others and as well as providing an active input towards the antibiotic plan or the antibiotic stewardship, development of guidelines and clinical pathway, seek multidisciplinary involvement and approval, incorporate local antimicrobial resistance pattern, which is a very important component. If you don't incorporate local antimicrobial resistance pattern, the outcomes could be a little different. The antibiogram which I was saying, if you look at some antibiotic might work in my ICU because considering the present kind of microorganisms which are present in my ICU or my antibiogram, my patients could be sensitive to piperacillin and tazobactam. But if you go to another hospital, which is a busy ICU where you have a lot of carbapenem resistance, ESBL or NDM, and a lot of microorganisms which are resistant. So there you have a different antibiotics to incorporate for the treatment, provide education and feedback to practitioners. This is, I think it's a very important slide. I specifically utilize this slide for my day-to-day practicing about the antimicrobial prescription. If you see the first, there is a patient which needs to be evaluated, that what kind of, and we have to choose an antimicrobials to prescribe. We can decide on the education or the guidelines strategies to choose an antibiotic. Similarly, you do decide about your restriction strategies, and then you prescribe the order, and then you follow the antimicrobial stewardship strategies. This is a beautiful slide which tries to emphasize how to prescribe antibiotics and what are the possible ways for antimicrobial stewardship strategies. The other elements for consideration could be antimicrobial cycling. It is usually not recommended. It's antimicrobial cycling means somebody has received this antibiotics for 10 days, then we switch to another antibiotics of similar generation or the other generation. There is a lot of insufficient data because now it is more of culture based or the diagnostic based, where we call it as diagnostic stewardship rather than antimicrobial cycling. The antimicrobial order form shows to be very effective component of the program and can facilitate implementation of practice guidelines. The combination therapy, although there is an insufficient data for routine use, but considering the present scenario, there is an increased coverage in the empiric therapy in patients with high risk as well as multi-drug resistant organisms, especially in the critical care setting or the intensive care setting. So combination therapy is definitely the possible recommended treatment in the present situation of the banned drug resistant organism as well as the extended drug resistant organisms, and which we are routinely practicing the combination therapy in our intensive care ICUs. And there is a lot of recommendation which is coming up for the use of combination therapy to improve the coverage as well as to increase the penetration of the drugs or to counteract the antimicrobial resistance which is present in our own country. Streamlining or de-escalation, this is a very important consideration or the element, because if my patient is either improving or I have a culture report which is available, which we call as diagnostic stewardship. Suppose we started on an empiric therapy and my patient is responding. One thing is we can de-escalate to either a lesser antibiotic or we can de-escalate to a higher antibiotic considering the diagnostic stewardship, which could be based on our cultures or PCRs. There is another concern which is a kind of a very important consideration and prioritization, which we call it as dose optimization. Dose optimization is mainly based on PK and PD parameters, which are the pharmacokinetics as well as the pharmacodynamic parameters. In my own critical care practice, we do practice a lot of dose optimization. We do believe in giving a higher bolus doses of antibiotics, as well as we do consider the PK PD, which we specially called as either, which is a recent modification, which we can call it as, it is based on the either a lot of antibiotics are concentration dependent, which we need to give them as a larger dose and a shorter duration of time so that the concentration killing or the concentration dependent killing is more. And there are a lot of antibiotics which works on the duration. So we need to give them on higher doses and a duration so that their concentration, this duration of action, the amount of killing is more. So they are usually being prescribed as 4 hours of infusions. Dose optimization, the bactericidal activity of beta-lactam, that is what I was saying. The extended interval, though some antibiotics are concentration dependent and some antibiotics are time dependent. Concentration dependent antibiotics needs to be given as a single shot and in a shorter duration of time, like aminoglycosides, fluoroquinolones. If somebody is prescribing amikacin 500 milligram morning, evening, I would prefer to give aminoglycoside as 1 gram as a single dose. If somebody is prescribing fluoroquinolones 500 milligram morning, evening, I would prefer to give 1 gram as a single low dose. If same goes for the concentration or the time dependent killing drugs, if you are using piperacillin and tazobactam, it will be preferable to use piperacillin tazobactam as infusion to be given over 4 hours to have better optimization of the drug and to have the better bactericidal activity. There is another important element or consideration. As quickly as possible, we can convert our IV antibiotics to oral antibiotics. It definitely reduces the healthcare cost as well as the length of stay, and development of clinical criteria and guidelines allowing conversion to use oral agents can facilitate implementation at the institutional level. Now, this is what we call as diagnostic stewardship, which is what I have seen over a period of time. This is a major development towards the antibiotic stewardship, because now we are, as soon as we prescribe our empirical antibiotic, considering a sick patient in ICU or emergency scenario or even an OPD or a ward scenario, there are a lot of diagnostic tools which helps us to decide what kind of antibiotics to prescribe, what kind of resistance mechanism my patient could be in. So there are a lot of investigations which can be assessed. Somebody, we are treating him on ATT, there are a lot of PCRs available, CB-NAT is available. Similarly, a lot of blood tests, you do culture, you grow some organism, you have the resistance mechanisms. So you can easily modify your antibiotic plan. Similarly, a lot of rapid genotypes tests which are available, rapid phenotypes which are available. Although there is a significant amount of cost is involved, but once we have a sick patient, there is a lot of emphasis which is given towards the diagnostic stewardship to have a better outcome. Because if we get to know whether we are treating bacteria, virus, what kind of bacteria, what kind of virus, the diagnostic stewardship plays a crucial role in deciding the overall outcome and as well as the important role in antibiotic stewardship. I think they go both hand in hand together to have a better outcome in the real scenario. This is a slide which I have taken from, I think, Journal of Antimicrobial Chemotherapy. It's a very recent data, which is considering a lot of MDR pseudomonas, what are the present situation, what kind of antibiotics which we can use. If you go through this slide, it clearly says culture confirmed MDR. MDR means multi-drug resistant organisms. Whether this is a carbapenem resistant enterobacterials, or it is a carbapenem resistant pseudomonas, or it is an MDR acinetobacter. The kind of resistance mechanism which you can evaluate by sending the appropriate cultures or sending the appropriate CRE cultures or the CRE modified test or the CRE modified resistance mechanism, you can get to know whether it is an OXA48, KPC, NDM, and whatnot. So based on that, we do decide whether what kind of antibiotic will work, what kind of modification can be done to tackle these kind of organisms or MDR bugs. But the only limitation as per our situation, what we are facing in India, we have only availability of ceftazidime and avibactam, but rest of other antibiotics which has developed in US, they are not available in India yet, especially the meropenem, barbactam, the cefiderocol, the ervacycline. A lot of antibiotics are not available. The only option which is available is what we have in India is ceftazidime and avibactam, and that does not work in NDM, which is the most common kind of resistance mechanism what we are seeing in Indian population. So we are still dependent on modifications or the combination of antibiotic plans. We do have modifications to give them in a higher dose. We do have combination of antibiotics, either a dual coverage antibiotics to have more gram negative killing. We do have empirical antifungal or the culture based antifungal, so that we do practice. So this is the present situation, the kind of multi-drug resistance organisms, how to treat. So considering the present situation, the only option what works well in our population is we do have colistin, but the present guidelines across IDSA or the CDC, the colistin is not there. But in our population, I have been using colistin and polymyxin along with high doses of carbapenem, and we do combine with either tigecycline, and at times we do give high dose of carbapenem, fosfomycin. These are the combination which is like little bit culture based, antibiogram based, or your experience based, I can say, in the present situation of AMR in India. The lot of risk factors which we can look at for antimicrobial resistance. There could be a delay in initial intervention, which is could be more than 24 hours, high severity of illness, advanced age, degree of comorbidities and degree of organ dysfunction, low albumin levels, poor nutritional status, peritoneal involvement, inability to achieve adequate debridement or control of damage, presence of malignancy, or prolonged hospitalization. These are the classical risk factors which we can look at for development of antimicrobial resistance. This is a very important slide which I have specifically made and shared with you, so that we do comes to a difficult scenario of antibiotic selection. There, that is a crucial aspect, because that is why we need more and more training towards the antimicrobial stewardship. If you prescribe an antibiotics based on your source or the expected source of bacteremia, the site of infection, what kind of pathogen it could be, what kind of source it could be, what kind of empirical antibiotics you want to prescribe based on your hospital antibiogram or the universal guidelines available, what kind of spectrum of cover we are anticipating to treat such bacteremia, what kind of site is basically involved in this kind of infection, whether I want to prescribe monotherapy or dual therapy considering the severity or the hemodynamic compromise. Do I prefer oral route or IV route? Do we need to consider the PKPD considerations to have this high risk of adverse effects? So a lot of things we consider before prescribing an antibiotics. We have to be very much selective in deciding an appropriate antibiotics, and that also to be given in appropriate time, in appropriate dose and duration. So this is a very, very important slide, and we need more and more emphasis towards the development of guidelines, development of more and more antibiotics programs, antibiotic teaching, as well as the antimicrobial stewardship programs. This is another slide which there is an intrinsic drug resistance. There are a lot of antibiotics which will not work, even they have been found sensitive in some reports or some cultures. If you look at this, if you use tigecycline to treat Pseudomonas infection, probably the tigecycline has got an intrinsic drug resistance. It will not work on Pseudomonas. If you prescribe for an NDMCRE Astrionam, probably this antibiotic will not work. So that is why I am saying the antibiotic selection is very important component, especially if you look at, if you are prescribing an antibiotic to treat an infection which there is an intrinsic resistance for that organism, so we cannot be that much happy in terms of prescribing those antibiotics. This is also a 10 Ds of antibiotics. It is drug, dilution, dose and dosing frequency, duration, the data of microbiology, the drug penetration, the drug resistance, the drug toxicity, the de-escalation, drug interaction, discuss, debate, and disagreement. I would like to emphasize more on the drug microbiology. If you look at what kind of organism it is, gram positive, gram negative, gram positive cocci, gram positive cocobacilli, gram positive cocci, so you can immediately modify your antibiotic plan in a very short span of time. By drug penetration means there is a drug which has got a higher penetration to brain. There are drugs or antibiotics which have higher penetration to lung, higher penetration to urine. So based on that, we do decide what kind of antibiotics to prescribe. Based on your antibiogram or the resistance, we do decide what, based on the toxicity of some drugs are having ototoxicity, some are having neurotoxicity, some drugs are having renal dysfunction, some drugs require dose modifications. Drug interaction is also an important component while prescribing antibiotics. Discussion is a very important component because until unless we discuss, there is a lot of multidisciplinary discussion, debate, and there is always a possible disagreement. Like my physician wants to practice this antibiotic is works well as per his experience, as per my experience, as well as the present guidelines. I would prefer this antibiotic is the preferred antibiotics to treat the present situation or the present critical patient in the ICU. So there could be always a disagreement, debate, or discussion. But these multidisciplinary meetings, we do share and we do come to a consensus. Let's plan it out. My antibiotic plan is to improve the patient. So that is how we come to a conclusion. What works well for this particular patient. To summarize, the antimicrobial resistance is a critical and threatening situation in India as well as across the globe. We do need to optimize antimicrobial therapy with a goal to improve patient safety. Collaboration is the key to a successful antimicrobial stewardship program. Identify and measure where improvement is needed to be implemented. Implementation and intervention is vital in overall success of the program, in addition to the patient outcome as well as the stepwise implementation. Antibiotics do cause a lot of ecological damage. Use them carefully. Antimicrobials to be limited to for a duration of 5 to 7 days until unless it is difficult to achieve source control. Avoid bacteriostatic drugs in sick patients. Avoid using two beta-lactams together. Avoid dual coverage until unless it is indicated. Avoid using vancomycin sensitive or staph. Avoid using vancomycin for sensitive staph or the streptococcus. The clinical indicators are the best guide, and diagnostic stewardship is must to ensure de-escalation of antibiotics. We have to be aware of the irrational or the absolute BL and BLI combinations. Trust your microbiologies, your local antibiogram, and the antibiotic practices. A small note toward the surgical prophylaxis: it needs to be given 30 to 60 minutes prior to your skin incision. If your OT time is prolonging more than 4 hours, you can give the second dose of antibiotics, or if there is a significant amount of blood loss more than 2000 ml, there also you can give second dose of antibiotics. Use narrow spectrum and discontinue within 24 hours. In India, our issues of antimicrobial resistance is related to NDM, OXA, NDM, and CRAB. CRAB is Acinetobacter baumannii, carbapenem resistant Acinetobacter baumannii. We don't have the antibiotics called cefdorocol, ravacycline, meropenem, barbactam, plazomicin, imipenem, celastin with relebactam. Only option what we have at present is ceftazidime and avibactam, which does not cover the NDM, which is the present kind of resistance mechanism what we are seeing routinely. We have colistin, polymyxin, fosfomycin, tigecycline, along with high dose of carbapenem infusions in different combination and higher doses. So we are struggling. I don't see there is a clear consensus, but we are still struggling for this antimicrobial resistance. So we are prescribing higher doses of colistin or higher doses of polymyxin in combination with tizicycline and a high dose of carbapenem infusion to counteract the present kind of situation in our own country. This is a slide which clearly incorporates everybody who should be a part of antibiotic stewardship program and how well they can contribute to the overall successful antimicrobial stewardship program. It could be either an infection control team controlling the source of infection, prescribing appropriate antibiotics, data collection, evaluations, supporting interdisciplinary approach, educating staff, collecting hospital-acquired infections, development of antimicrobial diagnostic stewardship. Everybody has a huge role to play. Nobody can perform alone unless it is a coordinated and an extended team efforts. This is just a continuation of our antimicrobial stewardship. We will be conducting a certificate course in antimicrobial basics and stewardship in our organization. This will be done on 27th March at Maharaja Hall, Santosh Medical College, Ghaziabad. I'll be the course director along with one of my colleague, Dr. Dev Pire Sarkar. The basic course objective will be covering a basic classification on antibiotics, antifungal, basics of microbiology and microorganisms, the antimicrobial resistance mechanism, rationale for the use of antimicrobials, infection prevention and diagnostic stewardship, the core concepts of antimicrobial stewardship, the clinical guidelines of antimicrobials use, assessing antimicrobial stewardship programs, role of healthcare professionals in antimicrobial stewardship, and antimicrobial stewardship in outpatient department. So in nutshell, we will be covering more or less the entire spectrum of antimicrobial stewardship and the emphasis towards the basic education on antibiotics and antifungals. This is just, and we routinely every year as per WHO there is a World Antimicrobial Awareness Week from 18 to 24th November. This is to spread awareness and to spread resistance and decrease the antimicrobial resistance across the globe. So I would like to say thanks, and I do want this education on antimicrobial stewardship to go on a larger scale, and it must reach or outreach a lot more doctors considering the present kind of a pandemic situation on antimicrobial resistance what in our own country and across the globe. So I would like to have more and more training and more emphasis towards the education, development of local guidelines, and development of antibiogram. And I think every hospital should develop their own antimicrobial stewardship team as well as the antimicrobial stewardship program to have a healthy future generation in years to come. Thank you.
Thank you so much, sir. I have a couple of questions from the audience. So my first question is, what is the role of extended infusion of antimicrobial agents in antimicrobial stewardship? Now, should the dose be decreased when an extended interval for infusion is used?
Yeah, if you look at why this extended infusion are being utilized, this is a very important question. I think the extended infusion is basically based on the PK/PD characteristics of the drug, and more or less there are drugs which are based on the time-dependent killing. So in those drugs, we definitely need to give them as infusion so that the drug is acting for a longer duration of time because it is a time-dependent killing. So if you give through infusion for 4 hours, definitely you have a better outcome. It has been validated as well. So that is the part of the question. The other question I think you asked whether the dose should be decreased for infusion. I think there is no dose to be decreased for this infusion. In fact, considering the present situation of lot of antimicrobial resistance which is prevalent across the globe, people are moving towards a higher doses of antibiotics so that you have better penetration as well as to counteract those antimicrobial resistance. So both questions we definitely need to give them as infusion for all time dependent antibiotics which are based on time-dependent killing. And we definitely don't need to reduce the dose. In fact, we increase the dose higher.
Rightly said, sir. This brings me to my next question. One of the factors for antibiotic prescriptions is to manage a viral or self-limiting infection. So, how should we change this mindset of physicians as well as patients' expectation to get treated with antibiotics?
I think this is also one of the crucial questions, which is kind of a day-to-day question. If you ask me, if we speak to 15 physicians, if we see lot much of OPD practices or outpatient department, there is a lot of mild self-limiting disease which patients are receiving a good number of antibiotics. Even the, if my experience or the government guidelines, they have incorporated so much of antibiotics, even that COVID protocols, which so-called from the government, it does involves a lot of antibiotics. Probably speaking, it's not required. Most of our viral illness are self-limiting. If for a simple URI or running nose or cough, even a mild dose of anti-allergic will work beautiful with little bit of antibiotic in the form of paracetamol in an appropriate dose. But prescribing those mild respiratory illness or URI, a higher dose of antibiotics probably is not required. We should wait and we should send some investigation, and most of the illnesses are self-limiting considering the viral etiology, and most of our URI are of viral etiology. And most of the patient, to my experience and to others' experience, even if you don't prescribe antibiotics, they will do well over a period of 5 to 7 days. Probably they just need reassurance. They just need little bit of anti-allergic. But it's actually difficult in OPD practices to convince somebody about not to prescribe antibiotics. Even the patient expects so much of treatment, but a good physician will always reassure his patient. I think you does not require an antibiotic considering kind of illness you have, kind of scenario or the kind of situation you are in. I think better you just take a mild course of anti-allergic along with little bit of antibiotics, little bit of steam. Probably you will improve well. If the things does not improve over 3 to 5 days, we would like to investigate you further, and then we can modify your plan and we can go ahead about it. This will act as a major source of cutting down the antimicrobial resistance. At the same time, the availability of over-the-counter drugs is also a major issue considering the availability of antibiotics. You can take any amount of antibiotics, any number of antibiotics, any combination of antibiotics across our all pharmacy stores in India. I think government should also come to some regulations of selling outpatient antibiotics, because if you go to the Western countries, lot of antibiotics, lot of medicines you cannot take on your own wish and will. You have to have a prescription from a pharmacist or a clinician. So that will act a long way in reducing the antimicrobial resistance, as well as the successful antimicrobial stewardship program. The major gold standard, I can still say there is a huge demand to educate more and more doctors towards the antibiotic stewardship, appropriate antibiotics, how to choose antibiotics, how to stop antibiotics, how to de-escalate, how to escalate. I think to my experience, to my caliber, I think government is already trying to put a lot more emphasis towards the program of antimicrobial stewardship through government level as well. But I think even medical students, the other allied branches, they should also go more towards the education as well as following the guidelines for incorporating antimicrobial stewardship in their routine practices to have a better and a healthy future generations ahead.
Thank you so much, sir. This brings us to the end of our session. So thank you so much for your efforts in putting together this useful session. If we receive any more questions from the audience, we would definitely reach out to you. And dear audience, thank you for your participation. Concluding today's session, please take care and have a great evening ahead. Thank you so much.